you elaborate further on your choice of triplet regimen? We have the PEACE-1 regimen with abiraterone and docetaxel, and then we also have ARASENS with darolutamide and docetaxel. Do you have a how do you talk to a patient about the data that's out there with triplet versus doublet, and what are kind of the patient factors you look at?
Sure. So I started with Charter trial initially with the chemotherapy for high risk or high volume disease. That's with 4 more lesions. I think one has to include the actual bones or the presence of lesion in the liver. So high volume disease, we typically try to intensify treatment. In regards to whether you want to add ABI versus DARA, I think it's going to be a question of side effects, liver toxicity, is the liver okay? I'm automatically thinking DARA at this point because it's been shown with these trials that do good either with low volume or high volume disease. And so if he's a candidate, I would do that. I don't know if, yeah.
I think it's very reasonable. I mean, I think the other thing you look at, in some of these patients is, abiraterone always comes with prednisone, and you've got to think, all right, how if you're going to put this patient on prednisone for years, is that your typical patient? Does he have bad diabetes? Are they frail? Do they have other systemic diseases that are going to make that a bad choice? So, that might be one of the, at face value, one of the key differences between the groups. And then, some of it's provider experience, right? So we've all used these drugs for different amounts of time, and you may get a feel for either drug, and both drugs are approved in the de novo space, as this patient had, essentially, I guess this guy was this guy metachronous over time, or is this the same patient from before, or is this a de novo patient?
Yeah, I brought up
hundred
a de novo patient.
Yeah, and so this patient with de novo disease, he definitely, he would qualify for either drug.
I think that the hazard ratios are in the 0.7s,
Yeah.
0.6s.
Yeah.
And so in terms of, looking at those things, I think is similar.
There was some ASCO 2025 data that maybe, if we can, look at a Decipher score, and the Decipher score is high in some of these patients, and, if, they also looked at, a PTEN expression. So if they had PTEN inactivity, those patients seem to maybe benefit more from the addition of docetaxel. And so it kind of, maybe there are things that will come out that will address this question of, does every patient need chemo, and hopefully some biomarkers in this space. But for now, I think we're all doing it based on volume, risk profiling, and a fit patient, or not. And so
that's one of our next step you got to, yeah. So especially with the liver metastasis, I think visceral organ metastasis compels us to use chemotherapy. Right. Well, let's say this patient didn't have liver metastases. Do you really have, are you really so that everybody needs a triplet for high volume disease? What do you think of the ARANOTE data? We now have darolutamide and ADT FDA approved based on the ARANOTE study, which is, as we all know, an ex-US study, but a very compelling study that met its primary endpoint for rPFS and trend towards overall survival benefit, but still not statistically significant yet. So based on that now available doublet, would you treat everybody with a triplet with high volume, or do you maybe select some patients for doublet?
I think if we could say they're maybe high volume, but still their risk grouping comes out still on the low side, potentially. I don't think there's maybe going to be a ton of patients, right? But if they come towards that grouping, yeah, you'd feel more comfortable not doing a triplet. And then, I agree that not every patient should get docetaxel. We've seen over time that when you can, in some of the, especially elderly patients, when you can sequence them, you may have, decent outcomes during the time they're on doublet therapy.
Other things to consider if you have genomics, or if you have some risk profiles suggested like P53 or RB1 or P10, all those type of factors in terms of high risk. Should you add chemo early on?
Yeah.
And then I think, I agree it's about symptoms too. Is the patient very symptomatic?
Glad you brought that up, David, because we all see these real world patients that might not be functionally feasible for docetaxel yet, but oftentimes we start with that doublet. And then by that time we have our genomics cooking, and we maybe see that TP53, RB1 loss, P10 loss, or maybe we see an SPOP mutation, which offers us that contrary prognosis as far as with ARSI responses. So, do you sometimes do that where you lead in and get the performance test improved and then decide to add in chemo months later?
But occasionally, I would say it's not common practice, but the doublet, as we know, has really good effect with the data in terms of just doing those two, and sometimes can have long durations of responses as well.
I think in the trials there was a little bit of a lead-in period that they allowed. I don't know if it was 12 weeks maybe in some of those trials, like after putting somebody on ADT and starting. So you don't have to start chemo at the same time. If you think your patient is fit and ready, you go ahead. And that's been my practice, is to go ahead and give all three at a similar time. But if I want to get a feel for the patient, like you're mentioning, that's something else. Also, as well.
Yeah, so there's actually two important cooperative group studies. One that's already opened by the CCTG and SWOG group. It's called Triple Switch. So actually, before I talk about that, what are your opinions about PSA velocity, or like getting down to undetectable levels versus getting to something above 0.2? I know there was some data at ASCO. Nilesh, what did you think?
So I mean, I'm not as familiar with the data itself, but obviously just in our practices, we typically feel like there's a better overall prognosis and better duration of their progression-free survival, the lower the PSA and the slower the velocity, just as a generic goal for prostate cancer management. So that's what we want to try to achieve, whatever therapy, whether it's dual ADT or triplet therapy.
Yeah, I think in general, the lower the better, right? I mean, that's what we're finding through multiple studies. I mean, I think Charted looked at maybe 0.7 as their initial number they were trying to go under, and then with ultrasensitive assays, we like under 0.2 for most of our systemic patients. And then Titan did a great ESMO update, I think one of the years, where they looked at an ultra low level 2, where they had patients go under, well under 0.2. And then I think they had about 20-some% that had reached that. So that was with apalutamide in that.
Right. Yeah. So our patients, from their perspective, they see 1600 going down to 20 and think, wow, this is a home run.
Yeah.
But we all know that we kind of plateaued there, and we didn't hit that deep less than 0.2 mark. We know those patients become castrate resistant much sooner. So Triple Switch is a study that actually looks at that. You start with the doublet. It's dealer's choice, so I like that. Dealer's choice, if you don't get down to a less than 0.2, then you get randomized to addition of docetaxel there versus continuing on that same treatment. And so they're looking for superiority over there. So, and then the other one is the Alliance trial that should open hopefully within the next month or two, called Aspire, that does use that gene signature, any two of the three tumor suppressor genes, and you get stratified by that group.